everyone to this super high yield explainer. आज हम एक बहुत ही important topic discuss करने वाले हैं, hemolytic anemias and blood loss. Listen, if you're gearing up for exams or you just really want to build rock solid clinical concepts, you absolutely have to understand the why behind these diseases. We can't just mug up the facts, right? So I'm going to break down these concepts exactly like we do in a live classroom. Grab your digital notebooks, get focused, and let's dive right into it.
आज के सेशन में we've got a really packed agenda. We're going to rapidly cover the basics of inherited defects, decode hereditary spherocytosis and G6PD deficiency, visualize some crucial peripheral smears, and finally unpack the deadly triad of blood loss.
Okay, kicking things off with Section 1, Inherited Defect Basics and the RBC Membrane.
So before we can even begin to understand how a red blood cell gets destroyed, we kind of have to know how it's built in the first place. The molecular architecture is literally everything here. You can see the textbook classifications, hemoglobinopathies, membrane defects, and zymopathies, but ध्यान से देखो the actual membrane structure. It's not just a simple balloon floating around in your blood. It is a highly complex scaffolding. You've got this lipid bilayer, and it's anchored by crucial proteins like spectrin, ankyrin, and BAN3. If that underlying scaffolding fails, the whole cell loses its structural integrity.
Write this down, guys, because these are straight-up MCQ points. For membrane defects, autosomal dominant transmission is by far the most common. And if they ask you which gene, the ankyrin gene mutation is your #1 answer, followed by BAN3. Now, if the question specifies autosomal recessive, you need to think beta spectrin. The core issue across the board is a defective pattern in the lipid bilayer, specifically those vertical and tangential protein associations. Basically, the structural glue is just too weak. Oh, and here's a super high-yield pearl to tuck away. Plasmodium falciparum, the malaria parasite. It actually binds with glycophorin, which is the most abundant protein on this RBC membrane. Keep that in the back of your mind, because we're going to come back to it.
Moving right along to Section 2, Hereditary Spherocytosis, or HS, and what I like to call the domino effect.
So how do those molecular defects we just talked about actually translate into a clinical disease? Well, here's your standard textbook pathogenesis flowchart. And if we follow the logic here, it actually tells a beautifully tragic story about the life of this cell. Let's break it down step by step.
Step 1. Because of that defective scaffolding, parts of the lipid bilayer actually start to pinch off. Little microvesicles form and detach right off the membrane. Step 2. Since the cell is losing its outer membrane but keeping all its internal volume, it has to physically change shape. It becomes a sphere. Why? Because geometrically, a sphere has the least surface area to volume ratio. It totally loses that perfect, flexible biconcave shape. Step 3. Normally, your RBCs are super flexible. They can easily stretch and squeeze through tight spaces. But this new, rigid sphere, it totally fails to elongate when it tries to navigate the tiny 3 to 4 micrometer capillaries in the spleen. It literally gets stuck. Step 4. And since it's stuck, the splenic macrophages come along, recognize it as abnormal, and destroy it. This is your classic extravascular hemolysis. Samajagya? The spherical shape itself is basically a physiological death sentence.
Because of all this ongoing destruction in the spleen, your patient is going to present with a very classic clinical profile. They'll have anemia, obviously. They'll have moderate splenomegaly, because that spleen is literally working overtime to clear out the bad cells. And they'll have gallstones, due to all the excess bilirubin from the destroyed red blood cells. You'll often see intermittent jaundice too. But listen up. Here's the examiner's absolute favorite trap, aplastic crisis. If a patient with known HS suddenly crashes with a massive drop in hemoglobin and a super low reticulocyte count, it is almost always triggered by a parvovirus B19 infection. Never, ever forget that.
All right, part 3, diagnosing and treating HS. You know the pathogenesis now, but how do we actually prove it in the lab? Exam boards love, and I mean love, testing if you know the difference between the best initial test and the most accurate test. Let's clear up that confusion right now. Ectacytometry is the most preferred modern investigation, period. However, if they ask for the absolute gold standard test to pinpoint the exact protein defect, that's SDS page electrophoresis. You might also run into the EMA binding test on your wards. What you really shouldn't rely on anymore, though, is the old osmotic fragility test. I know it's a classic, but it has terrible sensitivity and specificity. It's practically obsolete these days.
Okay, so we've diagnosed it. How do we treat it? Well, it depends entirely on how bad it is. Mild disease, usually just picked up incidentally in adults, and honestly, it only needs supportive care.
Moderate disease, where you're seeing anemia and gallstones, usually requires a splenectomy, but we purposely delay it until puberty. We want to preserve their immune function for as long as possible. Now, severe disease is totally different. You'll see this early in children, presenting with severe jaundice and high complication risks. For them, we go in and do the splenectomy early, around 3 to 4 years of age. And guys, always remember, preoperative vaccination against encapsulated organisms is an absolute non-negotiable must before you take any patient's spleen out.
Shifting gears now to Section 4, we're getting into enzymopathies, specifically the X-linked condition G6PD deficiency.
I want you to really think about this for a second. We just learned that ankyrin mutations cause the cell wall to literally fall apart. But why does lacking a random enzyme inside the cell cause it to burst? What is the actual biochemical reality going on here?
To figure that out, we have to zoom in on the HMP shunt. It is all about oxidative stress. Let's isolate this biochemical pathway so it's crystal clear in your mind.
Let's just follow the steps logically. Step 1. G6PD is the crucial first enzyme in the HMP shunt. Step 2. This reaction is incredibly vital because it creates a byproduct called NADPH. Step 3. That NADPH is then used to generate something called reduced glutathione. Step 4. Reduced glutathione is the absolute superhero of this story. It acts as an antioxidant shield, neutralizing free radicals and protecting the red blood cell from oxidative injury. So, connect the dots. No G6PD means no NADPH, which means no glutathione. Without that shield, the red blood cell just gets shredded by oxidative stress. Bold, simple concept, right? But it's highly, highly testable.
Now, what actually triggers this oxidative stress? Certain precipitating drugs. You have to memorize this list for the words. Antimalarials like primaquine and chloroquine. Antibiotics like dapsone, sulfamethoxazole, and nitrofurantoin. Even super high doses of aspirin or vitamin C can do it. Watch out for methylene blue and rasburicase 2. And of course, the granddaddy of all exam buzzwords, fava beans. Eating fava beans is strongly associated with triggering the severe Class 2 Mediterranean variant of G6PD. And don't forget, just a run-of-the-mill infection can act as a major trigger too.
All right, Section 5, high-yield smears.
The answer they call these images because visual questions are free marks on modern exams if you studied properly. We need to actually see the cellular damage we've been talking about. Look at this collection. We've got Howell-Jolly bodies, blister cells, helmet cells, which are your classic sign of fragmented hemolysis. Over here are echinocytes, which you'll see in CKB or pyruvate kinase deficiency. We even see basophilic stippling. And remember, that's a key marker not just for lead poisoning, but also for 5' nucleotidasedase deficiency. But I want you to focus specifically on the top right for a second.
Look at the amazing narrative connection between Heinz bodies and BITE cells in G6PD deficiency. When the cell faces oxidative stress without its glutathione shield, the hemoglobin denatures. It literally clumps and precipitates inside the cell. We call those clumps Heinz bodies. Now, as these damaged RBCs pass through the spleen, the macrophages act like a quality control team. They see the clump and they literally take a bite right out of the cell membrane to remove the Heinz body. And that leaves us with exactly what it sounds like, a BITE cell. The whole disease process is right there under the microscope.
Last section, number 6, the blood loss triad. We've talked a lot about chronic destruction, but now let's talk about acute severe bleeding.
When a patient loses a massive amount of blood, their body attempts to compensate in 3 distinct stages. Stage 1 is acute hypovolemia, just a sheer, immediate drop in total blood volume. Then in stage 2, the body gets desperate. To keep blood pressure up, it shifts fluid from the extravascular space directly into the intravascular space. This suddenly dilutes the remaining red blood cells, which is exactly why a patient's hemoglobin drop might only become apparent on their labs a few hours after the trauma starts. Finally, stage 3 is the bone marrow kicking into high gear. Erythropoietin, or EPO, surges, pumping out young RBCs and causing a massive spike in the reticulocyte count.
But what happens when the bleeding is too severe and this compensation fails? You hit the trauma triad of blood loss. This is a terrifying, vicious cycle consisting of hypothermia, acidosis, and DIC, which is severe hypercoagulability that quickly leads to bleeding out. It's a loop. The patient gets cold, which impairs their coagulation enzymes. That makes them bleed more. The bleeding causes poor tissue perfusion, leading to lactic acidosis, and that acid further poisons cardiac function and coagulation. Breaking this cycle in the ER is literally a matter of life and death.
Okay, before we completely wrap up, let me leave you with one final crazy evolutionary pearl. Remember back in the beginning when we noted that the malaria parasite Plasmodium falciparum binds to glycophorin on the RBC membrane? Well, both hereditary spherocytosis and G6B deficiency share this incredible trait. Being a heterozygote for either of these conditions actually protects you against malaria. The altered, defective red blood cell environment makes it way harder for the parasite to survive and replicate. It's a brilliant evolutionary defense mechanism.
Which brings us to a really provocative thought to end on today. If evolution is willing to protect us from deadly infections like malaria by hardwiring these red blood cell defects into our populations, what other genetic diseases out there are actually just hidden survival mechanisms? Keep studying conceptually, keep asking these why questions, and you are absolutely going to crush your exams and become brilliant clinicians. Thank you so much for hanging out with me in this explainer, and I'll catch you guys in the next one. Keep revising.